Hello, I'm Brenda Whitley, Community Relations Manager at Texas Health, Harris Methodist Hospital, Hurst-Euless-Bedford. Welcome to our physician panel on the neuroscience services offered at Texas Health HEB. Let me introduce our panelists to you. Dr. Stephen Hurlbut with Neurology Specialists of North Texas, Dr. Rob Ruska, neurosurgeon with North Texas Neurosurgical and Spine Center, and Tim Katera, Director of Rehabilitation Services here at Texas Health HEB. Dr. Hurlbut, let's start things off by describing the kind of services Texas Health HEB offers to help diagnose and treat neurological conditions.
So HEB offers a variety of things. We've had for several decades now full-service neurology care. So we've been able to take care of stroke patients, epilepsy, any type of complication of MS or dementia. We've not been able to take care of some of the neurosurgical issues up until now, which is a new development for us. But we're able to handle the majority of neurologic conditions that would bring people to a hospital.
So what kind of conditions do you typically see?
Well, we see a lot of at the hospital. We see a lot of stroke, so patients who either are worried that they've had a stroke, they have symptoms of weakness or difficulty talking, something that makes them worry they've had a stroke and brings them to the emergency room. We see a lot of that. We see a lot of people that have complications of some type of issue like back pain, weakness in the legs or arms. We also sometimes see people who are having complications of chronic neurologic things like Parkinson's or Alzheimer's. We also see MS patients who are having a flare-up of their condition.
So what treatments do we have available for those kinds of conditions?
So for those, most of those things are treatment that we really have trouble doing quickly in the outpatient setting, where in the hospital we do them quickly. So a lot of it is diagnostic tests that we can get done quickly, so like MRIs, ultrasounds of the neck and heart, different type of x-rays of the body that technically could be set up as an outpatient, but would take us usually several days or weeks to get everything organized. In the hospital, we can get everything done usually within a day. And then we can come up with a plan, and the treatment plan can get started here in the hospital. So if it's medication, especially if it's medicine that requires an IV, we can get that started right away. And then we just come up with our plan, and then the plan is continued usually as an outpatient.
So generally, when a person has a condition or a problem, they will go to their primary care physician first. What role does that PCP play with overall neurological care in their diagnosis and their subsequent treatment?
Primary care is kind of usually where it all starts. Usually the patient already has a relationship with the primary care. They either have a symptom or a problem that's been slowly getting worse that the primary care is aware of, and they've been monitoring it, and then it reaches kind of a tipping point where they feel like they need to seek out neurologic care. The issue has reached a place, so if it's weakness or headaches or a symptom related to their underlying condition like their Parkinson's, and the primary just feels like they aren't able to manage that properly anymore. And then a lot of that doesn't require inpatient treatment. That a lot of times the primary care then is referring the person to the neurologist or the neurosurgeon for the treatment that they need. Sometimes it's an acute thing. You know, they call their primary care because they have weakness on one side and they're worried about a stroke, or they have some type of acute issue that makes them unsafe at home. And usually then the primary will send them to the hospital, and then that way they can get the testing that they need that we mentioned. We can start on the therapy, you know, so if it's the physical or occupational therapy, whatever it is that they need then to kind of try to get better quicker. But the primary care usually kind of helps the patient decide. Usually the patient calls, I have this issue, and it's usually the primary care that's making the decision, come into the office, let's see you, or you need to go to the hospital.
So Dr. Ruska, we have neurosurgeons, we have neurologists. How does a patient know which one to go to?
Yeah, that's a difficult thing sometimes for the patient to figure out, and I think a lot of the times they can rely on their primary care doctors and also the neurologists that they see to decide when is the right time to see a neurosurgeon. Sometimes I have patients that skip those steps and see me, and that's perfectly fine, and then we have to backtrack a little bit because not everyone that sees me needs surgery. And I see my job as a lot of times people see a neurosurgeon or see a surgeon and think that we're always looking, for surgery, but really it's seeing patients that could benefit from surgery. And the majority of patients I see actually don't need surgery. So in that case, refer those patients for physical therapy or potentially refer them back to their primary care doctor or neurologist and get them to someone that can help them. And then in some cases, you can really help patients with surgery, and then we go down, that path.
So if surgery is necessary or an admission to the hospital, what can a patient expect in terms of their hospital stay and their overall recovery?
From a neurosurgery perspective, it's very dependent on the actual pathology of the patient and very dependent on what exactly is going on with them. If they need a surgery, for instance, for pressure on their spinal cord and their neck, there are procedures where they're in the hospital for just one day and then getting back to a very normal life after that. There are sometimes patients have more complex problems where it's a little bit more of a prolonged stay, like 3 or 4 days in the hospital. Something that I do is I also do minimally invasive spine surgery, which I think helps a lot with getting patients in and out of the hospital quicker, and also doing day surgery where patients come into the hospital and don't need admission and leave the same day.
So Tim, many times post-surgery rehab is needed. So can you tell us what that entails?
What that would be is if someone has surgery, they would come in with a referral. The physician would write an order for us, kind of indicating what they want, maybe if there's precautions or something like that we need to avoid. And then what we would do is we would do an evaluation, physical therapy evaluation, and set up a treatment plan for them and try to progress them to maximize the benefit of the surgery as well as maximize their independence. So, if they were having trouble getting around at home or they had maybe weakness in their leg or something, maybe we develop a treatment plan that would help strengthen their leg muscles after the surgery, whatever pathology was causing that weakness. Then we would work with that. We work closely with the physicians, whoever refers to us.
Sometimes surgery isn't needed though. And so can you talk a little bit about physical therapy as a non-surgical treatment and the services that we offer here at HEB?
So at HEB, we're fortunate to have physical therapy, occupational therapy, and speech therapy. We offer all the service lines there. We also offer land therapy, so therapy as far as with exercise equipment and stuff, but we also have a pool. So if the person needs aquatic therapy, we have that as well. We offer a full line of speech therapy, so even swallow studies, maybe if the individual needed help with that. Our occupational therapy department, we have certified hand therapists, so if there's hand issues, our occupational therapists can see that. We have lymphedema as well. And then going down the physical therapy line, we got the sports specialist and neurospecialist as well. We're fortunate to have therapists that have went to extra training and have specialties in those areas. We treat vestibular patients, so people that are dizzy. And as Dr. Hurlbut mentioned, Parkinson patients. We have a big and loud program, and so that involves speech therapy and physical therapy, and it's an intense 4-week program, 4 days a week that they come to help maintain their independence and their disease. It's not going to stop the disease progress, but it will help them work with it to maintain as independent level as they can.
Our physical therapy program is very good because I've been here since '03, and so it's nice because we have so much. A lot of places don't have speech therapy. Very few places have hand therapy. Very few places have the big and loud. So what's nice is that when I send people over to Tim's, is I'll send and then I'll get a evaluation back from the therapist saying, what you wrote, this is what we're doing. We really think this patient would benefit if we did the aquatic therapy, we put them in the pool, because it's an actual pool. It's not a small. Sometimes you send people for aquatic therapy and what they get is basically a large hot tub, but ours is a pool, and it's really, they have to have the lift to get them in and out, and classes, so that makes them feel comfortable. So there's just a lot of options in that building. And sometimes it's stuff I hadn't thought of, but the therapist thinks of it after they've evaluated the patient. And if I have to amend my order to allow the patient to, that's easy to do. And so it's a very dynamic back and forth. And it's just a very good, we're very fortunate to have the physical therapy, the extent of physical therapy that we have.
And we work very closely with the physicians. We send them updates on how their patient is progressing, so they know. So on a follow-up visit, they know exactly, okay, this is what you've done in therapy. I see what you've done and how you're progressing. And so they can have that dialogue too to see if the physicians need to change something up, add something, or whatever they need to do.
So Dr. Ruska, what do you specialize in? What is it that you do the most?
So as a neurosurgeon, neurosurgeons do brain and spine surgery mainly. We do some other things like surgery on nerves on the arms as well. My practice is focused mainly on minimally spine first and minimally invasive spine when possible. So the typical patient that I see in clinic, some of the more common conditions are when the nerves in the neck, whether that's the spinal cord or the nerves exiting, have pressure on them, and that can cause pretty significant pain that goes down their arms, or pressure on the spinal cord can cause them to have weakness in their hands with like their grip strength, or difficulty with walking and instability with walking. So that's a very common thing that I see and treat in clinic. The other is in the back, having pressure on the nerves. It can cause people to have difficulty walking long distances and getting weakness and soreness in their legs when they walk long distances. And along with, you can kind of compare the neck and the back, and then when you have an individual nerve that has pressure on it, that can send pain down their leg also. They can be very severe. And taking the pressure off of that nerve can get someone alleviated of that pain very quickly. But the conservative approach is always taken first, which includes the physical therapy, definitely in the first 6 weeks. And then also there are other methods other than surgery, as far as referring to a pain management doctor that can inject steroids and numbing medication around that nerve to try to get these patients out of pain without surgery. And that is always tried in the beginning, for sure.
And this can be any age. This can be a trauma.
Any age, and there are conditions that affect people more so when they get older. General arthritis can build up in the spine with age over decades, and so you do see conditions in the elderly population that's more common than you don't see as much as in someone that's 20 or 30 years old.
You touched a little bit already on collaboration, but we know that is really important to healthcare. Specifically here at Texas Health HEB, how do you see the surgeons and the technicians and the therapists working together?
Typically, a typical patient might see their primary, say, for back pain, and it's been going on for a while, and now the pain's starting to go down their leg. And maybe the primary's not sure where to send them, so say they send them to the neurologist. And so I might order the MRI, and sure enough, there's the arthritis that's building up, the wear and tear changes. You're like, is this a surgical thing or not? If it's, we sometimes do a test that tests the nerve in the legs, and we decide, and if we're not sure, and we're not sure it's risen to the place where the person needs surgery, I may, talk to the surgeon, say, could you look at the films? What do you think? Usually the first step is always conservative. So we send them to Tim, we maybe get the pain management, we tell the patient, we're gonna try this first, and if this makes your symptoms better and we can get you to a better place. If they get better, then great. If they don't get better, then say, okay, we're not better, then we get Dr. Hruska involved, and then he takes over. And when he's, fixed them, then, sometimes the patients will come back to Tim and I, it's an ongoing process between, really between the three of us,
And as we're seeing them, like if Dr. Hurlbut has referred to us and we're seeing them and we're just not making progress. We may not go the extent of what he ordered and said, this is kind of what we're seeing too, and kind of, send them back and say, what do you think? And then that's where Dr. Hruska would come in and things like that. So we're in constant communication, and that's important.
And one way that a neurologist and a neurosurgeon work together is that sometimes a medical condition that a neurologist treat can overlap with similar symptoms as problems with the spine. And you definitely don't want to be in the situation trying to treat someone with surgery when it may be not the problem and it could be a medical problem. So having Dr. Hurlbut here and their good group of neurologists is really nice to be able to run ideas by them to see if it could be something medical or not related to what I'm seeing them for.
We're all on the same medical record, so we can read each other's notes. So that helps. If you're not sure what the other person's thinking, you can just look. And even if we haven't talked yet, you can just read each other's notes.
We've expanded our neuroscience services here by bringing on a neurosurgeon. How does that benefit our community to have that here?
Well, I think it benefits the community by keeping patients in the community. Previous to that, I was working in THR, but in downtown Fort Worth for a few years, and I would see the patients from this community there. Coming to this community, I think will help keep everyone close to home and in the medical system here. I don't think there's any reason why that shouldn't happen, because we have a large, nice hospital here and all the specialties to take care of the patients here too.
So it keeps the patient here and closer to their family, and we know that it's important to have family in their care as well, involved with their care as well.
Yeah,
So.
never fun to travel when you're dealing with something as far as a medical problem. It's always nice to be by family, of course. Yeah.
That is the number one, I think, big thing, is that we get to keep people here. And this is where they want to be, and for how things are after the surgery, they're here, and so there's little break in continuity. If I send them to Tim for therapy before surgery, trying to prevent it, Dr. Hruska will probably send them to Tim for therapy after surgery, and so it's the same group, maybe different types of therapy, but it's the same group. So it's just really nice that Dr. Hruska's here. We've been waiting for having a neurosurgeon here for quite a while, because we could do things up to a point, and they always got really good care when we went downtown. But it's just different, There's just a lack of continuity when they go downtown, because it's just different neurologists, different everything, and so it's just very nice having him here.
So I've been asking a lot of questions. Is there something that you have thought about that you would like to share, or something in particular to where you work?
I feel like the community here supports our hospital really well. So I just would encourage them, to continue to support with all the things that are going on with COVID. I know a lot of people worry about coming to the ER, worry about coming to the hospital. The hospital really has taken a lot of efforts to keep everybody safe. And so, if you feel like you need to access the ER or access the hospital, don't be afraid to come. We are really making efforts to keep people safe here. So I think that would be my message is, we really have a good hospital here. And THR has put a lot of money into expanding the things that we're able to provide. And we've got the doctors and the support to do that.
And I would piggyback on that as far as therapy goes. The precautions and cleaning measures that were taking place when a patient comes in for therapy over in our outpatient clinic. Just the safeguards that we have in place to keep everyone safe and so that they hopefully feel comfortable in a safe environment and not worry about, am I going to get something or something like that. So we've really gone above everything and really doing well with all that.
Dr. Ruska, you've been in Fort Worth. What drew you to this area?
I think, like we were talking about the community before, a sense of community and the location here kind of reminds me of where I grew up as well. I grew up in Texas in Dripping Springs near Austin, and so the community I think just kind of fits my personality a little bit more than Fort Worth, and I saw an opportunity to to create a good practice here and take care of patients well here too. I think it's a good setup. The hospital has been very supportive as well, and speaking with Frazier and all the leadership of the hospital, felt a lot of support that they are really invested in having a neurosurgeon here and growing a neurosurgery practice here.
As our emergency room physicians and our intensivists.
Yeah, just all around everyone that I've spoken to, I had a very good feeling about that coming here.
We are a community hospital. We started that way over 40 years ago. We plan on being around for a long time. To your point, Dr. Hurlbut, Texas Health Resources has invested recently a lot in our OR suites and interventional radiology, ICU. So there really isn't a reason why a patient can't have all services done here. And so we're very proud of that, and we welcome you as well. It's obvious, gentlemen, that you have a passion for what each of you do. How did you get started? What brought you to it?
For me, so I grew up in Texas. I grew up in Forney. I went to medical school down in Galveston and went to Louisville, Kentucky for my residency and fellowship. I chose neurology. I decided in Galveston I didn't want to be a primary care. I wanted to be a specialist. And I made the decision that I wanted to be a specialist where I could be with people long term. So I think, and we had a really, really good chair of neurology in Galveston that just kind of was the person I wanted to be when I grew up, Dr. Calvary. And so, so I think that's what appealed to me. It allowed me to kind of zone in on a particular area of medicine, so I could feel like I was competent in it. And I've got patients. So my first job in Tarrant County was at JPS. I was there for about 10 years before I came over here. And I still have patients that have followed me from JPS. So I've got patients now that are 25 years my patient, and I really like that about neurology.
I would say that my initial draw towards neurosurgery has probably changed over the years, and currently what I really enjoy about my profession is the ability to basically make people feel better and quickly do it. So, for instance, we were talking about earlier, someone that has severe pain down their leg from a compressed nerve, being able to do a small procedure that maybe takes an hour and a half and having them leave the hospital that same day and the pain gone is probably the most gratifying thing that I do on a daily basis. And it's great to see people walking when they're in so much pain where they're even having difficulty walking. And so that drives me day to day doing those things.
And Tim?
I've always liked people, always liked working with people, and I always liked what drew me to physical therapy is wanting to work with people and help them gain their independence, some things, diagnosis that people get, it's challenging, whether it could be traumas and stuff like that, and trying to get them to be as independent as they can so they can live a full life. Whatever that involves, as far as from a physical therapy aspect of it. And so that's really what drew me to to physical therapy, is just to be able to work with individuals and families of the patients as well as the patient themselves, just to increase their independence. So maybe the family members don't have to care for them as much because the patient can be more independent, things like that. So that's what's drew me to therapy.
Thank you, gentlemen, for being here today, Dr. Hurlbut, Dr. Ruska, Tim, and for your expertise. And thank you for watching. Should you like additional information about the neuroscience services offered at Texas Health HEB, please go to our website at texashealth.org/HEB.